but this one particular symptom is extremely debilitating, but only because this can lead you down further problems. Hey everybody, welcome back to the channel. I'm Dr. B. This is Dr. B Addiction Recovery, and the topic I've been asked to discuss today and do a little bit of dive on is protracted withdrawals. Let's get started. Protracted withdrawals. I left it general on purpose because this gives me an opportunity to briefly hit what protracted withdrawals is for multiple psychotropics in addition to opiates. So when we talk about protracted withdrawals, generally what we're describing or discussing is past the acute withdrawal stage, if there is any. And what this really implies, again, depending on what substance or pharmaceutical we are discussing, we're talking about weeks to months, potentially years of this. And this topic has become sort of more open to discussion and more discussed in online communities with people experiencing protracted withdrawals secondary to benzodiazepines and secondary to antidepressants and to a less extent other psychotropics. But I want to first discuss opiates and people suffering from opiate addiction, and once they stop, one of the things that happens if there is no medication-assisted treatment is protracted withdrawals. In the case of opiates, it's often referred to as PAWS. That is an acronym, and it means post-acute withdrawal syndrome. People often describe that as the psychological issues that are related to long-term withdrawals that last several weeks to several months, which could be depression, which could be anxiety, which could be sleeplessness. But I think it's important to note that over 30 or 40 years ago, we have even been able to measure physiological disturbances, including blood pressure, heart rate, and I believe even cortisol levels in withdrawal situations with opiates up to 8 months out. And we also know that in terms of opiates, this also includes cravings. And so protracted withdrawals in the case of opiates is a very common cause of relapse, to the extent that in our practice, if someone comes up 2 to 3 months away from opiates, and they're telling us, you know what, I want to get on medication-assisted treatment at this point, I have cravings, and I often feel like using. What that tells me is that they're in protracted withdrawals, and they may very well relapse really quickly. And so I have no problem starting somebody on medication-assisted treatment in the post-acute withdrawal stage of opiates. But let's get to the other stuff. So that's for opiates. We're seeing more and more of this stuff with benzodiazepines and even with antidepressants. The details of the case of how they got to that point is a bit too much to go in this video, but what's important to note is that people are presenting with some of the following symptoms: anxiety, panic attacks, fear of the public, inability to focus and concentrate, dysphoria, depersonalization, derealization, auditory sensitivity, emotional lability, akathisia, which is a sense of inner restlessness, and I'm not going to go too much into it, but this one particular symptom is extremely debilitating and a cause of attempted or thoughts towards suicide. So you're seeing these people that are kind of presenting or not. Oftentimes they may be going to multiple doctors, and the doctors are not really addressing any of the issues and don't know what to make of it, okay? And oftentimes there's been a long history of whether it's multiple psychotropics, maybe some substance abuse, oftentimes benzodiazepines, oftentimes antidepressants, in addition to a history of trauma, whether it's an adult or childhood. And they're significantly debilitated in various ways, and they're coming in to the office presenting that way. In addition, one of the things that is happening almost across the board from what I've seen clinically, and this is not really in the clinical literature, it may be in the future, but I've certainly been able to observe it across all of these patients. If I can give one piece of information here, whatever doctor you go on to, if I can give one piece of information to all of these patients out there, is that you are what I call psychotropic hypersensitive moving forward. What do I mean by that? If any doctor wants to start psychotropic medications, whether it's antidepressants, whether it's something for sleep, whether it's a sedative, you have now sort of oftentimes with these patients developed extreme sensitivity of how this stuff will make you feel. That being the case, the practitioner should be very aware of that and approach this stuff with caution, close observation, and ready to change directions early on and quickly before it has more significant debilitating impact, whether it's psychological or otherwise, on the patient. The other thing that is sort of ubiquitous across the board with these patients is many of them have sought the help of multiple providers over time. Some of them have inappropriately gone into rehabs because they didn't know what to do. That being said, it causes more problems at times because they get started on a medication, come off a medication, go a different route, go into behavioral therapy, stop behavioral therapy. This sort of adds to the complexity and leaves patients perplexed, hopeless, and sort of feeling helpless. Another issue that I see with a lot of these patients is many of them, out of this sort of helplessness, hopelessness, despair, not knowing what to do, they turn to online communities. Okay? I don't want to put down or disparage any of these communities because everyone's there sort of out of desperation. But in particular, the benzodiazepine patients, the very reason they started it was for some sort of anxiety disorder. And interestingly, the very process, the pathological process of anxiety and the medication was supposed to help them, they have turned on that medication, and the anxiety has, the medication has sort of become the obsession for the issue of how they got to this situation. And so they get into this ruminating, obsessive, compulsive type of behavior, depending on who the person is and how they're expressing it, by following these online communities, listening to advice of all kinds of people, oftentimes well-intentioned, and sometimes people that are just trying to make a buck. I highly advise against ruminating and turning into the online communities for the answers, not because people on there are not well intentioned, but only because this can lead you down further problems. I hope this has given you some understanding of the issue. I hope you have found that this issue is recognized and there's some empathy and compassion. But I really want to warn that the best approach is sort of a collective approach with you, a provider that's going to approach this in a chronic way, in addition to a mental health provider besides a medical one that stays with you and sorts this stuff out. Thank you very much for listening, and take care.